The next speaker is a member of our board of advisors. His name is Ed Glick. He's a registered nurse. He works in Oregon, and we call him Nurse Ed. And I'd like you to give him a welcome, please.
My name is Ed Glick. I'm a nurse. I want to spend a moment and thank Mary Lynn and Al for this incredible gathering, and I want to also thank the California Nurses Association, because as a nurse, I believe that we are critical to the implementation of cannabis medicine into this society. I also want to express my heartfelt thanks to Todd Miccaria, who he may or may not be here. I saw him floating through earlier, and I have the highest regard for him. He's a very father-like figure in many ways to me, and he carries himself with grace and dignity and intelligence that is exemplary, and I'm proud to be in the same room with that man. He's a wonderful man. I want to thank Santa Barbara City College as well for hosting this. I'm not going to spend a lot of time here. I know everybody's hungry and tired, and actually after the PTSD panel that we just heard, emotionally I'm a little bit deflated because of the life and death nature of what we're doing here. And I think no matter what we're doing, if it's research or nursing or physician care or if we're patients, it's life and death, because every one of us could be in that situation that Al or either of the other panel members were in. But I want to just very briefly describe that as many years as I've been doing this work as a nurse for about 25 years, I've been working half of that time in acute care mental health nursing at Good Samaritan Regional Medical Center in Corvallis, Oregon. And about 10 years ago, 8 or 10 years ago, the Oregon Medical Marijuana Act passed the initiative process, and the registry began registering patients. And it wasn't long at all before I started meeting patients coming into the regional mental health unit who were reporting that they were using cannabis to medicate, quote, self-medicate a variety of mental health symptoms. It wasn't long after that that I started volunteering at the Compassion Center, which I should hold up their brochure. I'm a board member and a volunteer nurse there. It's a volunteer medical facility which helps assist patients with education and support and registration into the medical marijuana program. Pretty soon I started seeing the same patients who were having psychiatric emergencies coming through the Compassion Center to see me for a cannabis recommendation, which I can't provide, and which actually they couldn't get because there is no allowance in Oregon for psychiatric treatments to be included on the debilitating conditions review list. It's all physical treatments with the exception of Alzheimer's agitation. That has pulled me both ways because I work in one place with a fairly conservative medical system. In Corvallis, a very progressive community. There's virtually not one doctor who will recommend cannabis for cancer pain or for severe nausea or AIDS or the whole medical system of Corvallis just basically said, no, we'll opt out. And so then I go down to the Compassion Center, and all these people from the medical system that I'm employed in come in, and they say, well, you know, my doctor told me he won't do it. He's afraid he'll lose his license. And so we assist these people by trying to find a physical correlation to their psychiatric symptom. If they're having PTSD symptoms, they might be sick. They might have physical symptoms. And so we assist people to go through this process of getting registered for some physical system which will qualify, or a physical symptom. But in looking at it, a high percentage of these people are also treating psychiatric symptoms. So I put together a very simple survey where I went through a chart review at the center, picking every 5th chart, writing information out, collating it, comparing it, kind of working all the details out. It's included actually in the handouts. And instead of going into great detail, I just encourage anybody who wants to read it to go ahead and read it. And it basically showed, I'll run through the details. We did 172 charts were reviewed, and the average patient age was 43 years old. All the patients were registered in the medical marijuana program. That was one of the inclusion criteria. 95% of the patients were registered for pain, and that continues to be the case in Oregon, as virtually the entire medical marijuana program is registered with pain patients, with people suffering severe untreated pain or poorly treated pain. Many people, 40% of the survey, had multiple qualifying conditions, not including psychiatric conditions. Nausea, most often it was pain with nausea or pain with spasticity, as I think Ed was talking, or George was talking about yesterday, that pain and spasticity often go together, and spasms. The results showed that basically 64% of the survey, of just me reviewing the documents, to review the pages that they had filled out to become a patient, to go through our clinic, 64% showed some kind of significant psychiatric benefit. It broke down basically 39%, almost 40% of the cohort reported insomnia relief, 5% reported PTSD symptom relief, and of course these are people who are using this for another physical condition. And a lot of the people with PTSD are veterans who go down to Roseburg and the doctor says, nope, can't go there. We don't do that. I'll lose my DEA license. So the VA doctors just don't want to stand up to it. But they are beginning actually to refer patients to us, which is kind of interesting. Anxiety was 11%. Depressive symptoms were 11% reports. And in addition, we had 15% of the survey reported decreased medication side effects, so they're actually using the cannabis to reduce the side effects of medications. 56% actually report reduced use of medications because they're using cannabis. And I ask doctors, and I ask anybody who's skeptical about the co-administration of cannabinoids to please monitor the prescription use patterns of your patients. And if you're wondering if your patient is abusing opiates, make a contract and monitor the prescription patterns before and after they start using cannabis. And what these patients reported to me and still continue to report is that they're sick and tired of Vioxx, and they're sick and tired of Flexeril, Vicodin. People are sick of these things. They literally, physically and emotionally, they can't sleep, they're drugged up, they can't function, they can't work, they don't have any enjoyment in life, and so they start using cannabis, and they leave off the Vioxx, and they leave off the Vicodin especially. It's horrible stuff. You know, it's got a place, but it's, for long-term pain management, Vicodin is really poor. Appetite stimulation was 20%, which was tremendous for people who are in pain all the time. They don't sleep, they don't eat. So it was really a remarkable, it was really remarkable. I put the survey together as a request to the Oregon Department of Human Services to reconvene the Debilitating Conditions Advisory Panel. And that was conducted in 2000. I was a member of it then. 9 patients at that time submitted requests to include psychiatric conditions on the list. The panel was convened. The state health officer did a fairly good job of bringing together a panel and getting it. He was very clear about it, very nicely done, except that the whole thing was skewed from the outset by political manipulation from the governor's office and from the head of the DHS.